neurology. Recording is now in progress, which is always a good thing, so we can podcast this later. We're very lucky today to have A presenting a case again and Vale discussing again. And looking forward very much to this. There is another VMR happening at 9, so we'll have to keep our eyes and clock to make sure and finish on time. Okay, I think everyone knows you, A and Vale, but if you want to just quickly introduce yourselves and then we'll get started.
Hi everyone, I'm A. I am a physician from VMR and now working as a clinical research at WashU. And I'll be presenting a case today, so I'm more excited.
Great. Okay, hi everyone, I'm Vale. I'm calling from Lima, Peru, where I'm working as I am an IMG going for neurology next cycle of the match, and I'm working as a research as well in neurocognitive decline and HIV. Excited for today's case.
Fantastic. All right, let's go ahead. A, what is the chief concern for today?
All right, the chief concern is 19-year-old female presenting with right hand weakness for 3 to 4 months.
Okay, right hand weakness for 3 to 4 months. What are you thinking, Valerie?
Okay, this is tricky for sure. I don't see this often. Okay, so first we have a young patient. We have a chronic time onset, and we have a very focal symptom, which is the right hand is weak. So when it comes to weakness in general, I often think about the corticospinal tract and, going from the brain all the way to the periphery, to the hand itself. And I think, it could be something on the brain that could be affecting specifically the the left prefrontal cortex, the motor cortex, specifically in the area of the homunculus that affects the hand. But it becomes less likely as we go down from, the corona radiata, where all the fibers kind of intersect, and we will have a more like total right side type of weakness, not just a focal like hand. And then we go to the brainstem, and then to the spinal cord. And the spinal cord, I think for me, a tricky localization, because I do believe, the fibers in the spinal cord that also have a distribution that usually is like from the periphery and then to the center. But of course, being the hand the only part affected, I'm thinking about, the roots and the nerves that go outside to the hand itself. And given that it is the hand and not the arm or the hand, the shoulders, or even like some muscles on the spine that kind of, are in the most proximal side of the brachial plexus, I will think about something maybe affecting the kind of the fibers that are in the most distal part of the plexus, like the radial nerve, the median nerve, the ulnar nerve, and then the nerves itself in their course through the hand, or maybe to the forearm, and then through the hand. So I will be very interested to see what is this pattern of weakness, if it's, with extension, with flexion, with, interosseo, or like the very small muscles that are in, to give the strength to the fingers. So yeah, we can go maybe later on how to do the strength exam on the hand, because I have some tricks that I usually do in my examinations. But I would love to learn from you, Aaron.
Yeah, well, I would love to learn from you too, Vale. That's a phenomenal discussion. I really have nothing to add. Just to highlight a few things by asking you a few questions. So you mentioned that weakness can occur from a lesion anywhere along the motor pathway, which goes from the brain, specifically the motor cortex, through the subcortical white matter, and the corticospinal tract that then descends through the brainstem, through the spinal cord, synapses on lower motor neurons, as you mentioned, which begin in the anterior horn of the spinal cord, exit through ventral roots to become the nerves of the brachial plexus, and then the brachial plexus gives off its nerves to the upper extremity. So those are all the possibilities. Excuse me. You sort of said this, but I think you did say this, but you said many brilliant things. So just to highlight for everyone, what do you think are the 1 or 2 most likely localizations if this is indeed isolated right hand weakness? Of all the places you mentioned, brain, brainstem, spinal cord, roots, plexus, nerve. Of course, we should say, sorry, motor neuromuscular junction muscle, but for it to be so focal, right? You didn't mention those because of just hand weakness from a neuromuscular junction or muscle etiology would be unlikely, it would be more diffuse probably. Okay, so of the locations you mentioned along the motor pathway, what do you think would be most likely the top one or two possibilities that rise to the top of your list? Sort of the differential of the localization, if you will.
Yes, I think for sure the nerves are in my top one category. I think if this was maybe an older patient, I would think maybe, oh, okay, can this be carpal tunnel or something like that? And, you know, to look for sensory symptoms. And then for a second place, I'm not really that sure. I think maybe the plexus, also given the chronic course of this patient, but I would love to learn from you.
Yeah, I agree for all the reasons you said, and I just wanted to highlight. Yeah, when you have just the hand, I agree the first impulse is something in the periphery, common things being common, something like a compressive neuropathy, median at the wrist or ulnar at the elbow. As you said, we'll have to get into the hand exam and see if the pattern of weakness fits with one of those specific nerves, or some type of root problem, the roots that serve the nerves of the upper extremity. So something in the periphery would probably be number one. But you did mention that you could get a central lesion causing just hand weakness if you got the motor area of the motor cortex or just inferior to that in the corona radiata, where the fibers, as you described perfectly, are still slightly separate, sort of hand or sort of upper extremity, face and leg before they come together. And then by the time you're in the subcortical white matter, deeper in the capsule, you're really all together. It would be hard to get just hand. As you said, you'd probably get face, arm, and leg, that type of thing. But you can get a small stroke, for example, in the what we call the hand knob. If you look at the precentral gyrus where the motor cortex is, there's some people call it the omega sign. Looks like the Greek letter omega. Kind of all the gyri look a little bit like that. But where the hand area is a little bump there. And if you think of the homunculus, it has those huge hands, right? Because the hand has so much dexterity and has so much use. So you can get a small central lesion that can look like a peripheral lesion where the patient just has isolated hand weakness. Of course, given that the hand is so important for daily function, it could be that the patient also has some more proximal weakness, and it's a sort of full upper extremity syndrome that the patient just reporting, my hand isn't working, because they're maybe not doing so much reaching on a top shelf to know that their shoulder isn't so strong either, or maybe, you know, the threshold of leg weakness they would need to notice, or maybe we just haven't asked yet, and this is the main thing. But truly isolated hand weakness, I agree, probably peripheral. And if that seems to be the case, we can dig into how you would distinguish median from ulnar, from radial, from root, from plexopathy, if that becomes relevant. So sort of peripheral versus a small central lesion. And you mentioned carpal tunnel and thinking they should be sensation problems as well. And yeah, usually carpal tunnel, the main concern people have before weakness, and even when the hand is becoming weak, is, yeah, painful paresthesias from the irritation, presumably, of the nerve in its myelin sheath. So it could be the patient will also tell us there's numbness, tingling going along with this, or pain. But if it's just weakness, then that makes sort of a probably peripheral compressive neuropathy less likely. What else? Yeah, that's sort of the localization. Okay, and then time course 3 to 4 months. But it's going to depend on the localization, I guess, right? So we'll maybe put that aside for now. Okay, so we're off to a start of something peripheral or something small in the brain. And I agree with you. Why not the spinal cord for isolated hand? Well, the cortical spinal tract and the cervical spine has hand and arm and leg fibers, right? So it'd be hard to get a lesion small enough to get just the hand fibers of the corticospinal tract. You mentioned, Valeria, that there is a topography there of how these fibers are laminated, with the upper extremities for the corticospinal tracts medial and the lower extremities more lateral. So a central cord lesion, maybe pushing on the more medial fibers, but still just on one side. Seems less compelling. For the leg, if this patient had isolated leg weakness, the spinal cord is still in play, right? Because once you're thoracic and below, it's just leg fibers in the cord. But when it's just hand, I agree it would be hard to invoke the cord here if there's really nothing going on in the leg. Now, maybe we'll learn that the patient has a little bit of a limp, or the patient has hyperreflexia in the leg on that side, that then would put the spinal cord back in play. But otherwise, I agree with you, brain or periphery. Okay, A, what did we learn from the history?
All right, such a great discussion as always, Aaron and Billy. So let me take you all the journey and see where the final localization will be. So this is a 19-year-old female with right hand weakness for 3 to 4 months. She noticed loss of muscle back in right hand, so loss of atrophy, and particularly in the region of the first dorsal interossei. This is associated with some weakness and dysfunction of the hand. So she particularly noticed difficulty holding a pen and difficulty updating her fifth finger, causing it call when she is putting her hands in her pockets. She is not experiencing any sensory symptoms, including no numbness or paresthesia, nor any pain, including no neck pain. She denies any similar symptoms in her left hand or as well in her body. No past episode of weakness, headache, seizure, gait abnormality, no history of orthostatic hypotension, fainting, or any bladder or bowel abnormality.
Okay. Anything we should know at this point in the past medical history, all that while we're
No past medical history, any surgical history. She is a nursing student and no use of like alcohol, smoking, or any other recreational drugs.
great. Okay, so we have a healthy young woman here, Valeria, with a little more information about what's meant by hand weakness. So based on A's perfect description here of the patient's very precise description of what functions of the hand are impaired, how are you thinking about the case now?
Yeah, I'm for sure outside of my comfort zone because I usually have an app actually that helps me with the peripheral nerves and the muscles. But okay, so we have difficulty holding a pen and difficulty adducting her fifth finger. I think with holding the nerve and also the pain in, or sorry, loss of muscle or like atrophy in the first dorsal interosseous. When it comes to the interosseous, I'm not sure if the first is an exception, and I'm just going to embarrass myself, but I often think about the ulnar nerve innervating them, and then the fifth finger would also fit in on that category, like the ulnar nerve being affected. And then when it comes to holding a pen, I'll think, the ulnar, because we do this, so the fifth is also affected, but then maybe also I would have to know if the first finger is also affected as well. I'm not sure. But I think, my first thought was, okay, the ulnar may be, the most likely nerve or the most affected thus far. And what could affect the ulnar nerve in a very young patient? I think, with this time course, we often think about things like could be growing and compressing slowly. And when it comes to the ulnar nerve, I believe it goes through the Guyon canal or the canal of Guyon, I'm not sure, in the wrist. Maybe something there could be compressing and, causing these symptoms. I'm not sure, and also to be like affecting only the motor fibers and not maybe the sensory fibers as far as we know right now. I'm not sure how these fibers are distributed in this very tiny canal. So I guess that's kind of my first thought. And then I also, when I saw the age of this patient, and also when A mentioned that her hand got stuck in her pockets, something that came to mind from my step 2 studying was also the possibility of, like, I believe there were mitochondrial myositis that I'm not sure, I don't remember exactly, but it was like hereditary type of myositis or myopathy, sorry, that could cause like a locked hand. And I remember, yeah, like you presented like a claw, almost like a locked hand, and it got better with movement, I believe. I have to refresh my memory on that, but that's another thing that came to mind. But yeah, I'm kind of putting the blame on the ulnar, but we'd love to hear from you, Aaron.
Yeah, brilliant, Valeria. Yeah, just to go with the last thing that you said, I think you're thinking maybe of myotonic dystrophy, where the hand, which is genetic myopathy, not mitochondrial, but it's hard to keep all the myopathies straight. Yeah, so you were wondering if the hand is sort of cramping up and that's why it's getting stuck. I think A is talking about a different type of finding here, related to the weakness in the hand of not being able to get it out of the pocket due to a specific function, which we'll talk about, which is sort of a classic sign. Excellent, Valeria. Yeah, I think lots of people know their central nervous system anatomy pretty well, but I feel like, as I often say to our trainees, neurology training is more inpatient and central nervous system focused, and it takes an extra effort to learn the peripheral nervous system. So good for you, still even applying to neurology residency, and you know your peripheral nervous system anatomy brilliantly. Just for others who are still learning this, or maybe have learned it in the past and are reviewing it, you mentioned you thought this was an ulnar neuropathy. Good for you. I agree with you based on what we know so far. How did you know that? How did you know it's not one of the other main nerves of the arm? And then I can, arm and hand, and then I can quickly go through my approach too.
Yes, I think my most basic sense of it is that the ulnar usually innervates, from the half of like the how do we say, like, well, in the distribution it will be like the median. Oh, sorry, the median will be from the the thumb, and then the middle finger, the half that is closest to the thumb when it comes to sensory, and then the ulnar will be the other half of the hand, and the same with the movements or like the strength. The median nerve also innervates and I'm thinking about the palmar aspect of the hand, of course, because the radial nerve usually innervates the dorsal aspect of the hand. And then when it comes to the strength, I think of the ulnar nerve innervating the small muscles of the hand, like the interosseous. And then, I mean, I usually remember this because of the injuries that happen when you are a baby and you have like a clavicle injury. You have like the claw hand when the radial nerve is affected. Then you can also have like the arb, something like that, when like it's like your hand is like this, when you also have like usually like the lower parts of the trunks of the brachial plexus, I believe, but these are where the median nerve comes from. Air palsy. Yeah, thank you, Gerardo, in chat. And then you have that ulnar nerve in which just the interosseous are affected, so you cannot do this. But yeah, I'm not sure if that's the most clear way to explain it. It's really not my forte.
Yeah, good for you. Yeah, good for you. So yeah, the hand is very complicated. That's why we're able to do such complex things with our hands. And a couple of nerves are innervating a lot of muscles that give rise to sort of complex structure, which is good for our dexterity, but hard as students of neuroanatomy to keep it all straight. Yeah, if you have to guess, as one important point you mentioned is almost all the intrinsic hand muscles are ulnar innervated. So you mentioned already the interossei, which abduct and adduct the fingers and thumb. I remember learning PAD and DAB as a student. PAD is palmar adduction and dorsal abduction. So the palmar interossei adduct and the dorsal interossei abduct. So that's one piece. As you mentioned, there's some intrinsic hand weakness here. The first dorsal interosseous, that's the sort of muscle belly over the sort of back between the thumb and the index finger, the dorsum of the hand is ulnar innervated, and you can't see the other interossei, but they're moving your fingers together and apart. And lots of muscles go into holding a pen, right? A little hard to know what to do with that, but difficulty getting the hand out of the pocket could be difficulty adducting your fingers, right, to get the hand back out. You mentioned whether that could be a cramp or myotonia, but I think that's what Dan's getting at here. Okay. So I don't know how other people learn this, but when I was a medical student, we learned the brachial plexus first, and the brachial plexus is super complicated. And so I find it more straightforward to teach and to learn first the main, most clinically commonly affected nerves. And if you know those nerves well, you can either identify for the purposes of clinical medicine or for the purposes of exams, well, it's one of these nerves. All the muscles and sensory territory affected fit into one nerve. Or it doesn't fit into just one nerve, which means it could be a root, because each root goes into multiple nerves and each nerve has multiple roots. And if it looks more widespread, it could be multiple nerves, or it could be plexus, or it could be central. So where I like to start with this is just knowing 5 nerves really well, 5 nerves of the arm really well. I think there's something like 11 more nerves that come off the brachial plexus. That's sort of more advanced level. But if you know these 5 nerves well, which I'll go through quickly you should be able to figure most of the peripheral cases out. Okay, which 5 nerves? Again, acknowledging there are, I think, 11 more nerves that come off the brachial plexus to do things related to the shoulder and some pure sensory nerves and other things that we won't get into. Which 5 nerves? Musculocutaneous, axillary, radial, median, and ulnar, which Valeria has already discussed too. Let's do the easy ones. Musculocutaneous. Do you know what it innervates, Valley? No problem if not, but we'll just go back and forth. Musculocutaneous.
Does it innervate by any and a muscle of the arm, like or like the sensor? I think the median part of like the sensory aspect of the arm,
Yeah, the
and
main thing
maybe
that
like the biceps.
biceps. Yeah, so I think of making a muscle. When people make a muscle, that's biceps musculocutaneous. Yeah, I think it has a small sensory territory in the upper arm, but that nerve is so short going from the brachial plexus to the biceps, you almost never get an isolated musculocutaneous nerve. And Gerardo is ahead of us here. What does the axillary nerve do? He's already typing it. I love to see it. Do you know, Valeria? He's helping you.
Yeah, I think the axillary is like the deltoid, and
Yeah, and I think Terry's minor, but I don't even remember what Terry's minor does. Again, axillary, very short nerve, very rare to get an isolated axillary neuropathy. If you see either of those nerves affected, you know, there's something very proximal going on that could be C5, 6, or root, or upper plexus. Okay, then we get into radial, median, and ulnar, and it starts getting more complicated. The radial nerve, the mnemonic I picked up at some point, I don't remember where I got this from, but I know I didn't make it up, is radial nerve is the best, and best stands for brachioradialis, extensors, supinator, and triceps. You sort of showed this, Valeria, but the radial nerve does the extensor compartment of the arm. So triceps, extending the forearm, all the wrist extensors, all the finger extensors, the thumb extensor for a thumbs up. And then supinator is, remember one of my medical school classmates, remember this, said, would you like some soup? And she supinated her arms. And then I never forgot that, even though that was many, many years ago. Okay, so radial nerve is the best extensor compartment of the arm. Brachioradialis, extensor, supinator, and triceps. The one exception to extensor is the brachioradialis, which does flexion of the arm in the half pronated position. So like drinking from a glass, you pick up the glass and you bring it up this way. It's just 90 degrees off from your biceps. That's a helpful distinction, little sort of gourmet neuromuscular here, that brachioradialis and biceps are both C6 innervated, but one is radial and one is musculocutaneous. So just by having the patient turn their forearm 90 degrees, you can assess, well, if they're both affected, that's 2 muscles from 2 nerves. So it's more likely more proximal, it's C6. Or if just one of them, then you know, the C6 root is okay because it was still able to do biceps by way of musculocutaneous. So it must be the radial nerve because brachioradialis is impaired rather than C6. So remember, I found this very confusing when I was first learning this. All of the roots go in, many of the roots go into multiple nerves, and each nerve has multiple roots. So C6 is going into musculocutaneous, it's going in to radial, for example, and there's all these sort of, and then both of those nerves have multiple roots in them. So this is the art of localization in the peripheral nervous system, where you say, if you really want to know all of this, you'd have to say the biceps is innervated by musculocutaneous and C6, and you would have to know where musculocutaneous comes off of the brachial plexus. So as you test these, if you're a neurology resident or student of neurology, you start saying, I'm testing biceps, musculocutaneous C6. I'm testing deltoid, axillary C5. And you just keep ingraining those so you can say, wait, all of these muscles affected line up with one nerve, or they don't, or they line up with one root, or they don't. Yeah. Okay, median and ulnar is where it gets complicated because the hand is complicated. As Valeria said, if you have to guess, draw a line between your middle finger and ring finger and what is medial, because the arms are in Da Vinci, whatever that codex thing is, Da Vinci position, with the pinkies medial and the thumbs lateral. You can't see because of the zoom camera, but whatever is on the pinky side, on the 5th finger side, is ulnar, and whatever is on the thumb side is median, mostly, with some exceptions. Median and ulnar don't do anything above the elbow. They do the long finger flexors, which are in the forearm, which you can feel when you wiggle your fingers. And then they split some of what's going on in the hand. So for example, flexor carpi radialis, I wish they called it medianalis because it's median innervated, but it's radialis because it's over the radial bone. Flexor carpi radialis, median, flexor carpi ulnaris, ulnar. get to the lumbricals, which sort of flex the fingers at the MCP in the extended position. First to our median, second to our ulnar. Unfortunately, one exception, flexor digitorum superficialis, flexing at the proximal interphalangeal joint, is all median. And then we're back for flexor digitorum profundus, the fingertips DIP is median and ulnar again. So it's median ulnar, all median, median ulnar. Okay. The thumb, thumbs up, extension, radial. Thumb in, adduction. That's adductor pollicis, that's ulnar, just like the interossei for adduction or ulnar. And then abductor pollicis brevis, that's the muscle belly that makes up the thenar eminence, that's median. And then abductor pollicis brevis, the APB, is the only median, one of the only median innervated nerves distal to the carpal tunnel. So not only do you need to know which muscles are innervated by which nerve, but where they're innervated, right? So the median nerve is most commonly affected in the carpal tunnel. And so the long finger flexors are spared because they're innervated proximal to the carpal tunnel in the forearm. But in severe median neuropathy, not all patients have it this severely, you can get APB weakness, abductor pollicis brevis weakness, but you shouldn't get the long finger flexors. If you do have median innervated long finger flexor weakness, it means you have a rare median neuropathy with compression in the forearm. That's very uncommon. On the other hand, the ulnar nerve, Valerie, you mentioned Guillen's canal, that's in the wrist. That's actually a less common site of compression. More commonly, the ulnar nerve is affected in the cubital tunnel in the elbow. That's the funny bone when you tap there and you get paresthesias in your distal hand. So ulnar is usually affected at the elbow, and that's much more disabling because now you're getting the long finger flexors in the medial hand, as well as all the intrinsic hand muscles we talked about. So we mentioned median on this side, ulnar on this side, and then ulnar for abduction and adduction. That's a lot of information. It took me 10, 20, 30 times through to really get the hang of this. There's a great video online if you look up Michael Charnas, examination of the hand. There's a video. He's an amazing neurologist at the Boston VA who I worked with as a resident, who also sees all the injured musicians in Boston who develop mouth dystonias and playing tremors and all kinds of injuries, repetitive strain injuries. If you look up this video, there's a beautiful video of him teaching the exam of the upper extremity. For each movement, he says what nerve, muscle, and root he's testing. I think there's an extra S on there, Gerardo. Okay, so there's a whole way of examining the arm and hand that takes this into account, where we sort of make sure the proximal muscles innervated by the more proximally functioning nerves, musculocutaneous and axillary, are okay. Here we're not hearing anything that suggests radial. All the things we're hearing suggest ulnar. Is there still a differential? Well, we didn't get into this, and in the interest of time, we won't, but I started off by telling you for each muscle what root innervates it as well, not just which nerve. So we'll have to see if every muscle we find on exam affected that A tells us falls into the ulnar territory and nothing in median or radial, well, we'll know we have an ulnar neuropathy. If there are things that fall outside of ulnar, then we'll have to ask ourselves, do they share a common root? So the interossei are mostly C8T1, for example. Are we seeing other non-ulnar C8 innervated muscles? Are there any? Opponent's pollicis, maybe C7, C8. I'm not sure. These are the things, and you start looking them up in tables or asking your neuromuscular colleagues. We didn't talk about the sensory. This patient has no prominent sensory symptoms, but we'll see. As Valerie said, on the palm of the hand, ulnar splits the ring finger and does medial, and median splits the ring finger and lateral, but the sensory exam is very difficult. It's very rare to get a pure dissociation of pinprick on both sides, and it's sort of hard for the patient, I think, to localize sensory symptoms. But one key thing to realize is that even though the ulnar nerve is running through the medial arm into Guillen's canal, the sensory territory of the ulnar is only distal to the wrist. So you can check this if you tap your medial elbow hard enough to get paresthesias, they're only distal to the wrist. And there's actually another nerve, the medial antebrachial cutaneous nerve, which comes off the medial cord of the brachial plexus, that does the medial forearm sensory territory. So if you think this is ulnar and you're checking sensory and the patient says it's numb, it's numb, it's numb, it's numb, it's numb, the sensation should come back around the area of the wrist. If not, you're more proximal, either in the medial cord or C8. The other thing to note is that there's a little palmar cutaneous branch that doesn't go through Guillen's canal, and one for the median that doesn't go through the carpal tunnel. So actually the sparing should begin slightly distal to the wrist for both cases if you have compression at the wrist. Isn't peripheral neuroanatomy beautiful? Okay. So we're going to be very keen to know here whether everything fits into an ulnar distribution or not. And if it doesn't, are we more proximal in the plexus, C8, or the patient is describing these very essential hand functions. If we see that extension is affected also, and we say, wait, is there a radial going on with this ulnar? Or do we start to wonder, does this patient have a small brain lesion that's affecting the most important dexterous functions of the hand? There is, if you get a small stroke in the hand knob, it's sometimes called a pseudo-radial, because the pyramidal pattern of weakness tends to affect the extensors, which are the triceps, wrist extension, finger extension. There's a fun clinical sign. So if you see a wrist drop, which is people think usually of a radial neuropathy, you're wondering, could this be central? If you ask the patient to try to make a fist, when it's a radial neuropathy and there's no extension, making a fist activates the flexors median ulnar and the wrist goes further into flexion. I've only seen this once after reading about it, and you have to have sort of just the right amount of weakness and preservation of strength. But if the patient has a central wrist drop and they try to make a fist, the wrist will come up a little bit due to some spared long extensor. I forget which one. That's part of the pyramidal innervation. Anyway. All right, so let's see. You can tell us for the exam if everything's normal except the right hand. You can tell us just in the interest of time the right hand exam. Before we do that, any questions, Valera? Any clarifying points? I know that's a lot of information there.
I'm ready for more information as well.
Okay, let's get it.
Right, so general examination are normal, neck, there's no pain, neck flexions or things like that. And so in neurological examination, so cranial nerves are all normal. On motor examination, there is prominent atrophy in the first dorsal introsures of the right hand, but there are also some atrophy of the hypothenar and thenar regions as well. There is no obvious atrophy in the left hand and no clawing. On motor power examination, shoulder abduction, adduction, elbow flexion, extension, they are all normal 5/5 on both upper limbs. And but for the right hand, wrist extension is 4+, but wrist flexion is 5/5, and finger abduction is 2, and adduction is also 2/5 on right hand. And finger abduction are like 3 to 4 on the left hand as well. And thumb abduction is 1/5 on right hand and 2/5 left hand. But on lower limbs, all the muscle power are all normal, like hip flexion, extension, knee flexion, extension, on all normal on both sides. And reflexes are all normal 2+, very normal reflexes of a young woman. On all bicep, tricep, supinators. And knee and ankle reflexes are also normal 2+, and plantar is flexor. On sensory examination, the pinprick testing shows equal sensation over second and fifth fingertip, bilaterally and throughout all major cutaneous sensory nerve distribution. So sensory is all normal. And other findings, gait are all normal. And yeah, so this is the end of our neurological examination.
Okay, let's make sure we got all that. There is mild wrist, everything's normal except the right hand. And in the right hand, wrist extension is slightly weak. Finger abduction and adduction are very weak. Thumb abduction is also weak.
Yeah.
We hear about finger flexion.
Finger flexion is 3/5 on right hand and 4 on left hand.
And do we have whether that's proximal, distal finger, or we just have in general? It's fine either way.
I think it is more like distant.
And it's across the whole hand, first, second, third, fourth digits.
I think it's all like all 5 digits.
Okay. And we heard a little left hand weakness also.
Left hand, there's a little left hand weakness.
And sensation is normal, reflexes are normal,
Reflexes are normal.
and sensation is normal. Okay, Valeria, is this an ulnar neuropathy?
It seems like not only a neural neuropathy, no. I think I'm a little confused because I think we have, I heard correctly that we have both hands affected, just the right hand more affected than the left, right? Yeah, okay. So, I mean, that bilateral nature of this presentation makes me, okay, we're still in the nerve territory when it comes to localization, but then what could be causing bilateral? What seems like maybe something affecting something more proximal than the ulnar nerve only, because there's also like wrist extension affected. So we will think maybe, as you explained, the radial aspect of it as well. And then we have thumb abduction completely, affected, and also in the left side. So I would think, the median nerve is as well affected. So I think the three nerves are affected. And in that case, I mean, those three nerves go through the elbow, but in very different localizations. So I would think, okay, maybe not in the elbow, but then they go all the way from the arm to the to very different trunks of the brachial plexus. So I would think, okay, maybe something compressing all three, branches going from, the upper, middle, and lower trunks of the plexus, or is something affecting even, but I will think it is less likely because we don't have any, proximal motor like biceps, triceps, or reflexes affected that could think, let me think like the other branches that you mentioned are affected. And then also the bilateral nature of this makes me think, it is really weird. Like, could this be like multiple mononeuropathies affected at the same time in both sides, like two radial, two median, and two ulnar, but why more in the right than in the left? That's also something that makes me wonder, maybe something that's starting in the right and is growing to the left side, but it will be very weird because it will be something, going all the way. So yeah, I'm not sure. I'm very biased because I did present a case of brachial plexopathy last week, secondary to a radiation injury. And one of the teaching points of that case was that, radiation can, migrate in that pattern, from one side to the other. So that makes me think, has there been any injury? But then again, the chronic nature of this, I don't know, makes me doubt a lot. So yeah, I think I know. I mean, I'm sure that three nerves are affected in both sides, but I'm not really sure what could explain it. And even if we are in the plexus, or really, I'm so stumped by this case. You never cease to impress me. So help me, please, Aaron.
Yeah, well, that was great, Valeria. You identified the most important piece here, which I said, if you know those five nerves well, you can say, hold on, this is not corresponding to the territory of one nerve, because we have the intrinsic hand muscles, abduction, adduction on one side, so that's ulnar. Then we also have wrist extension, that's E for extension, the E in best, so that's radial. But then we don't have all of radial, right? We don't have brachioradialis or triceps. So how would we get just one muscle group from radial? And then we have abductor pollicis, brevis, atollis. So we have median, but it's only median distal to the wrist. So it's hard to imagine all three nerves are affected, but incompletely affected. That doesn't totally line up, right? So we have to move more proximally. Do we have some plexus or root injury or root process? Do we have something central? And then we hear that the left hand is involved also. So as you said, something would have to be very oddly shaped to get both hand areas of the brain, forget it. The brainstem, forget it. There's no cranial nerve problems. Both plexuses, well, not something structural kind of going across and missing the heart and lungs and all the things that stand between the most important neurologic structures, some of those other, as Marty Samuels called them, some of the lesser organs that might get in the way there. So how to define the syndrome here? and it's a little bit difficult. Do we say that this might be asymmetric bilateral plexopathy? You also use the term mononeuropathy. We sometimes learn this term mononeuritis multiplex, but mononeuropathy multiplex is the better term because not all of those are itis, some are opathy. So how to think about this case? And it's pure motor, right? There's no sensory involvement. I said after you learn those 5 nerves, well, the next step is to go learn the plexus and say, well, the median comes off of that sort of M, and that's really getting stuff from the upper and lower plexus. The ulnar comes off of the lower trunk medial cord, and then the radial comes off of that posterior middle trunk posterior cord. So we're really tracing everything back to the plexus, right? So we're probably still in the periphery, and then the question now is, we're probably between a brachial plexopathy and a mononeuropathy multiplex, but it is pure motor. There's no sensory, there's no pain. The reflexes are preserved. So what do we do with that, Valeria? I agree with your localization. We're in the periphery. We're probably plexus or multiple individual nerves. Median and ulnar, there are no reflexes there. Radial, we don't have the proximal to get the triceps reflex, to knock it out. I mean, because we know that the triceps is strong here. It's a little hard to know what to do with the spared reflexes here. And yet we have a lot of atrophy and preserved reflexes. So using the fact that there's no sensory involvement here, what are you thinking? Yeah, as you said, it makes it hard to imagine there's a structural lesion compressing roots or compressing nerves, causing no pain and no sensory loss. We have a pure motor peripheral process. What does that make you think of?
Well, when you put it like that, like a pure motor peripheral process, I think, I mean, when you say pure motor, I think ALS, but
Yeah.
you often think about the mixed signs when it comes to that disease. So I'm not sure the fact that we only have like very peripheral signs. But I mean, the reflexes are normal, so they're really pointing towards upper or lower motor. And then the fact that it is absence of sensory symptoms, I think that points me away from neuropathy, the neuropathy hypothesis. But at the same time, I'll be like, why is there no other muscles or nerves proximal affected that could explain a very specific lesion in the plexus? Or I mean, then again, maybe it is an injury that it's very, 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 very like specific, only affecting those 3 nerves in both sides for some reason, and it's somehow spread. What I'm trying to say, I guess, is that maybe a variant of ALS that is very, very tricky. But I guess the sensory point me away from the neuropathy hypothesis.
Yeah, we've talked about we got anchored early on a focal peripheral localization, a single nerve. We then learned from the exam it's not a single nerve, so we thought of multiple nerves or plexus. But when you have a pure motor presentation, yeah, you have to think about ALS, and to hear there's significant atrophy here with spared reflexes, some bilaterality here that does start to raise the specter of motor neuron disease. It's described in ALS something called the split hand, where there's, I don't know if you mentioned if there's APB atrophy, but there's certainly weakness where the APB and the first dorsal interossei are atrophied and weak. So one is median, one is ulnar, but the hypothenar eminence is relatively spare. That's called the split hand of ALS. Maybe that could be here, what's happening here. There's another motor neuron disease worth mentioning here called Hirayama disease, which causes unilateral or asymmetric or bilateral upper extremity weakness, usually distal predominant, and the reflexes can be spared. It's an interesting disease. It's from some sort of laxity of the anterior, I think, soft tissue structures of the spine. So in these patients, if you do a normal spine MRI, it looks normal. But if you do an MRI inflection with the patient sitting up, it shows that there's some anterior compression where there's compression of the anterior cord, the anterior horn cells. I saw one case of this, actually not as a patient. It was a piano student of a piano teacher who I had studied piano with, who said my student was diagnosed with this. Can you check him out? And I was said I can't really be his doctor unless he comes to see me. But I was so curious that I can sort of meet him for coffee and examine him and see if I agree with this. And I think he did have it. Usually they get a lot of forearm atrophy. If you Google pictures of this, it's a very unique appearance where a lot of forearm atrophy and the hand sort of looks oversized for the arm. There's no pain here, but there's a condition called Parsonage-Turner syndrome, which is a immune-mediated or rarely genetic brachial plexopathy/itis. Usually the illness script there is very, very severe unilateral pain in the axilla or shoulder. No one finds anything. And then as the pain resolves over days, the arm and hand become weak. But that condition almost always involves the more proximal aspects of the plexus with scapular winging and shoulder weakness, and affects particularly a branch of the median nerve called the AIN, anterior interosseous nerve, which does the flexor pollicis longus and flexor digitorum profundus 1 and 2. So the patient tries to make an okay sign and they do this. That being said, it's a disease that can behave in lots of different ways. Not all patients have sensory loss. I saw a case recently of actually unilateral. I didn't see that patient, but a resident told me about the case of unilateral hemidiaphragm elevation and arm pain that was an isolated phrenic neuropathy that was attributed to this condition. But the lack of pain would be atypical. There is a pure motor peripheral neuropathy that's kind of a cousin of CIDP called MMN, multifocal motor neuropathy. That's multiple individual motor nerves affected. It does tend to begin in the distal upper extremity. It's associated with a GM1 antibody discovered right across the hallway from you, in the lab of Dr. Pestronk at WashU, I believe. I was just reading about this condition yesterday to update my book. I've never seen a case of this. I don't know if this is quite how it would present. Okay, so we're now thinking about motor neuron disease, plexopathy, multiple nerves. Valeria, if you were going to order one single test to sort out the localization here, what would it be?
I think it would be an EMG, which was what I was hoping it was not good. I think it will be that. What do you think?
Yeah, I would like to know what's going on as well from a localization perspective. And if you talk to neuromuscular specialists, they'll say the EMG is an extension of the neurologic exam. It's not like an EEG where you just plug it in and then you get the waves and you look at it. By seeing what nerves are affected and where and what muscles are affected, where the neuromuscular physician will then say, huh, if these are affected, I'm either in this nerve or this root. If I test this one more muscle that may not be weak on exam, but may have findings of denervation, then I can answer the question that way. So it's an extension of the exam that allows us to access physiologically muscles that might not be clearly affected on exam. I'm aware of the time, and we do have to finish a minute before 9 for the other VMR. So we're saved, Valeria. Don't worry, I can't interpret the EMG numbers or anything also. So we'll let A maybe tell us what the EMG showed and nerve conduction studies showed as far as the localization, and we'll see, Valeria, if we can make a final diagnosis. Uh-oh, she's going to show us the waveforms. Oh, no.
Yeah, so we just did the connection study and EMG. For right hand motor nerve connection study, right median motor, radial motor, ulnar motor, they show small compound muscle action potential without connection block or distal latency, and connection velocity are normal. So for the left, motor nerve connection study are all normal. And for right, sensory nerve connection study, the lateral antebrachial medial antebrachial median ulnar and radial sensory nerve connection study are all normal. We can see here like these sensory nerve action potential are all normal. There's only pure motor. And EMG shows they did like all 9 muscles in the right hand, and especially like fast or central so show active denervation with fibrillation potential, as well as recruitment of only a single fast firing broad polyphasic motor unit potential. So yeah, I will stop it here. The first MRI cervical spine is normal. They just do with just like normal cervical MRI.
Got it. So just in summary, we have decreased amplitudes with preserved velocities and no conduction block, the general neurologist version of this. Valeria, do you know, no worries if you don't, this distinction between seeing low amplitude but normal velocity as opposed to if you saw decreased velocity, what that signifies as far as type of physiology here?
Yes, I remember. Actually, might not. But like amplitude indicates like the peripheral nerve is affected, and then actually I don't remember, so I would love to learn from you.
Yeah. So the amplitude is a reflection of axons. So if you just think of the area under the curve of that nerve conduction, the more axons you have, the bigger that curve will be. And if you lose axons from an axonal process, then the amplitude of the CMAP, the compound motor action potential, or SNAP, sensory nerve action potential, will be lower. On the other hand, remember the function of myelin is to speed neuronal transmission. So if you have a demyelinating process, then you are going to slow the conduction velocity. And if you have that slowing over a particular point where 2 points stimulated recorded proximal or 2 points stimulated recorded distal are okay, but across a segment of nerve is impaired, that's called conduction block, suggests focal demyelination, particularly acquired demyelination rather than genetic. Okay, we have some type of axonal process affecting multiple nerves. Actually, this maybe doesn't help us that much more. We sort of knew that based on the exam. So we have multiple nerves of the plexus affected. We've had axonal loss. If we wanted to know if that was more proximal, we could do something called an F wave, where you stimulate. And the stimulus doesn't just go forward to the muscle, but it actually goes backward through the nerve, stimulates the cell body to fire, and you get a second waveform. And if that is delayed or absent, it tells you there's some more proximal dysfunction. So that's something that might help us here. Okay, we have a normal cervical MRI. You can get imaging of the plexus called a neurogram. People get this a lot where I work now at UCSF. It's rare. I don't know how to look at them, but I find that it's rare that you see something specific on there. But you can see enhancement or enlargement of the brachial plexus and inflammatory processes. Okay, so I think we're back where we were. Could this be motor neuron disease? It's pure motor. Could it be something like ALS? That would be very unfortunate, but not impossible. Could it be this other motor neuron disease I mentioned, Hirayama disease? Rare, but possible. Could it be this multifocal motor neuropathy that characteristically has conduction block? I believe it has to have that in more than 2 nerves, which we didn't see. It's a demyelinating disease, cousin of CIDP. They did say, maybe speaking to the question I asked before, that her supine cervical MRI was normal. So I wonder if you were giving me the clue A that I was on the right track with Hirayama disease, that another MRI with her in the head flex position showed, is it subluxation of the anterior longitudinal ligament or whatever it's supposed to be, and then some compression. We have 2 minutes, A. Bring us home. Where did you and your colleagues land on this case? How did you make a final diagnosis? And just to clarify, why are Valeria and I struggling with this case? Well, it's multiple nerves, so it seems multiple nerves or root or plexus, but sensation is normal and reflexes are normal. So it makes it hard to call this purely something just kind of affecting peripheral nerves. It's a pure motor process, which makes us think it's motor nerves, which makes us think that motor neuron disease, which fortunately is not always ALS, but that is on the table here. Or is it this other motor neuron disease called Hirayama disease? Very, very uncommon disease, but A loves to bring us very uncommon things. Okay, I took 1 of your 2 minutes, A. Sorry, tell us, bring us home.
So yeah, we just did a repeat MRI. Can you see my screen? I think.
Yeah.
Can you see the
Yeah, it's still starting to share.
I'm sharing the cervical spine.
It says has started screen sharing, but let's try again. Yeah.
Try it again. So, Okay, sorry. Sorry about that. I'm showing the cervical MRI cervical MRI, but it's not appearing here. So we just did a repeat MRI cervical spine with flexion, and there is ventral displacement of posterior during merging on flexion images from C5 to C7, causing compression of the cord, mid-cord thinning, and probable myelopathy signal from C5 to C7. Trace C3 on C4, C4 on C5, C5 on C6, and C6 on C7 anterior subluxations during flexions. With the striking like features of chronic and some ongoing denervations and C7, C81 muscles of the upper extremity in a context of like small median ulnar combined muscle action potential with robust preserved sensory responses. These findings all together support a preganglionate lesion localization. And chronic and focal nature of the denervation does not suggest a more extensive motor neuron disease, such as ALS or SMA. And the neurologic examinations show normal non-pathologic hyperreflexia of a young woman. So the clinical picture in electrodiagnostic study such as Hariyama disease. And yeah, this is Aaron, you said you have seen one case. I have also only seen this one case.
We've each seen one case, and there was a prior CP Solvers Hirayama case. I think we podcasted it a few years ago. I'm forgetting that presenter's name from India. I haven't seen him in a long time. So very rare, but 2 times in CP Solvers. Yeah, Gerardo, if you remember it, maybe you can recirculate it and see if we hit all the same points. Is this a case you saw in Burma, eh?
No, this is from neuromuscular clinic that I'm sharing here at St. Louis.
Fantastic. All right, well, we are out of time, and I want to respect the time of the next VMR, but really wonderful discussion, Valeria. You know so much peripheral neurology, which is fantastic and rare amongst neurologists, let alone aspiring neurologists. And as always, bringing us the most challenging, most interesting cases, and we can all learn so much from you and from these cases and from Valeria. So while it's still 9 o'clock in respect of our next VMR, thank everyone for joining us. We'll do another one, I think, in February. Valeria and A are putting together. Let's definitely podcast this episode because we all learned a lot. And everyone enjoy the rest of your day. We'll see you all soon. Thanks again, A. Thanks, Valeria. Thanks, Gerardo.
Thank you. Have a great day.
Hello. Bye.